Hello everyone and welcome to set 13 of the part 1 questions. Let's get going. First question here, what is the most common renal malignancy in adults? What is the associated gene deletion with this malignancy? So first, what is the most common renal malignancy in adults? So this is going to be renal cell carcinoma. And this is a classic presentation of hematuria, flank pain, and a palpable flank mass. Now, what is that associated gene deletion? Well, renal cell carcinoma is associated with a gene deletion in chromosome 3. Also, it is associated with von Hippel-Lindau syndrome. Next, what does the eustachian or the auditory tube connect? What is its purpose? What drug is commonly prescribed for eustachian tube dysfunction? So this connects the middle ear to the nasal pharynx. It makes the pressure in the middle ear the same as the atmospheric pressure. And then what are we going to use as a treatment? Usually it's the intranasal steroids. Next question. A 24-year-old man is fired from his job, and when explaining the chain of events to his roommate, he explains that it doesn't really matter. I didn't even need that job anyway. His roommate is perplexed, wondering how they will pay their rent. Of which immature ego defense could this be an example? So this is an example of rationalization. Next, a pediatric patient presents with a noticeable right flank mass. The patient's mother also reports blood in the patient's urine. What malignancy would be most likely in this scenario? So this is going to be a Wilms tumor, so we also refer to this as nephroblastoma. And you want to suspect this in a 2 to 4-year-old with flank mass and hematuria. Now, second part of this, what is the WAGR complex? So this is the tetrad of Wilms tumor, aniridia, genitourinary malformation, and mental motor retardation. And it's caused by a deletion of the WT1 tumor suppressor gene. Next, a 22-year-old man who recently immigrated from a developing country is seen at this county health clinic with a complaint of a chronic but recently worsening productive cough and sinusitis symptoms. He also mentions to you privately that he and his wife have not been able to have children despite trying for 2 years. While you note this last complaint, you order a chest x-ray out of concern that this may be TB given with his immigration status. The chest x-ray appears backwards on the display, but you realize this man's heart is actually on the opposite side of his chest. What is the primary defect in this syndrome, and what are the characteristic symptoms and signs? Long question, but a good one to know here. So this patient is presenting with Cartagener's syndrome, also called primary ciliary dyskinesia, which is a defect in the cilia, which are non-modal, so as the name implies. So because of this, they can have a bronchiectasis where the bronchioles won't stay open, and they can get respiratory tract infections and cough. They can also have recurrent sinusitis, and what's interesting, they also have infertility because of that immotility actually occurs in the sperm as well. Now this can be associated with situs inversus, which we saw in this patient, where all the organs are actually swapped left to right. Next question, what is the definition of tidal volume, residual volume, and vital capacity? So first we have tidal volume. This is the amount of air that moves in and out of your lungs with each normal, quiet breath. Then when you blow out as much air as you possibly can, and this is the amount of air left in your lungs, this is the residual volume because you can't really ever completely empty your lungs no matter how hard you try. So you blow out all your air and that's what's left over. The vital capacity is the maximum amount of air that you can take into your lungs minus that residual volume. So you measure this by taking a deep breath, as deep of a breath as possible, and then blowing out as much as you can. That volume that you blew out is the vital capacity. All right, next question. When screening a population for a particular disease, would you rather have a high sensitivity or a high specificity? And then what test is used to screen for HIV? What test is used to confirm a positive HIV screen? So when screening a population for a particular disease, you would rather have a high sensitivity because that high sensitivity, you can think of sensitivity as the probability that a person with a disease will actually test positive, so you're going to catch more of them. Now, which test is used to screen for HIV? Well, the ELISA test is used first. It has a very high sensitivity, but also has a high false positive rate, which is why a highly specific confirmatory test, such as the Western blot, needs to be performed if the ELISA is positive. So if the ELISA test is positive, which is high sensitivity, and the Western blot test is positive, which is high specificity, then the patient indeed will have the disease, in this case HIV. Now, what test is used to confirm a positive HIV screen? Remember, we just said this, Western blot. Western blot, don't forget that highly specific, high false negative rate. All right, next question. A mutation in which proto-oncogenes is most commonly associated with Hirschsprung's disease. All right, so this is going to be the RET gene mutation. So RET codes for proteins that assist cells of the neural crest, which later become ganglion cells in their movement through the digestive tract during the development of the embryo. Next question. Amyloidosis and sarcoidosis are associated with which cardiomyopathy? What are some other diseases or conditions associated with cardiomyopathy? So you're going to get something like restrictive or obliterative cardiomyopathy in these situations. Anytime you bulk up a tissue with a substance such as amyloid or the granulomas of sarcoidosis, you're going to actually restrict the function of that tissue. Now, what are some of the other diseases or conditions associated with this cardiomyopathy? So you don't need to know all the causes, but a few worth knowing for step one are post-radiation fibrosis, endocardial fibroelastosis, Loeffler's syndrome, and hemochromatosis. Next question. How do primary and secondary hyperaldosteronism differ in their effect on plasma renin levels? What agent is used to treat primary hyperaldosteronism? So primary hyperaldosteronism is caused by an aldosterone secreting tumor, which is going to decrease plasma renin by a negative feedback mechanism. And secondary hyperaldosteronism caused by the JG apparatus of the kidney perceiving a low intravascular volume, and that's going to be associated with a high plasma renin. Now, what agent is used to treat primary hyperaldosteronism? That's going to be spironolactone. So spironolactone is a potassium-sparing diuretic that works by acting as an aldosterone antagonist. All right, guys, so we got to the end of that one. That's the end of set number 13. I hope you learned something. I'll see you next time.